Hello, and welcome to the 7th event in our 8-part speaker series. I am Tegan Henke, Senior Director of Program Implementation for the Child and Family Policy Team at the Meadows Institute, which, as you know by now, is an organization focused on helping Texas be a national leader in treating all people with mental health needs. Thank you so much for being with us today. We have a packed schedule, so we're going to jump right into our housekeeping notes. Today's session is in webinar format where all attendees are muted, and we encourage you to submit questions using the chat or Q&A function on your screen. This 55-minute session will be recorded and will be posted on our website within a few days. And if you'd like to watch or rewatch any of the previous webinars, you can find those recordings on our website. If you miss any of them, you'll definitely want to check them out. We've covered a range of topics, including an overview of implementation science, ways to use data to drive decision-making, selecting evidence-based practices for your organization, and we've had rich discussions about cultural humility and how it supports health equity, as well as ways to address childhood trauma and grief. It's been a big year and we've learned a lot, and those resources will be there for you to access on our website. Okay, on to the main event. For today's webinar, we have 3 of the best in the business, Drs. Carol Alter, Seema Shah, and Andrew Carlo. I will first welcome Dr. Carol Alter. Dr. Alter is the Associate Chair of Clinical Integration/Operations and Professor of Psychiatry and Behavioral Sciences at the University of Texas Austin Dell Medical School, as well as serving as a Senior Fellow for Medical Integration at the Meadows Institute. She has over 30 years of experience in diverse settings, including clinical practice, research, administration, and healthcare innovation, delivery, and policy with a focus on psychiatric care of patients with medical illness. Most recently, she served as a system lead for behavioral health at Baylor Scott & White Health, responsible for development of behavioral health services, including the collaborative care model. She is the chair of the American Psychiatric Association Council on Quality Care and leads efforts with national employers and health policymakers to ensure that measurement-based care is delivered across all behavioral health services. With that, I will turn it over to you, Dr. Alter. We're so lucky to have you here today.
Thanks, Tegan, and really happy to be here. And welcome everybody. So we'll jump right into it. I mean, today we're going to talk about a number of things, and my job is to try to create a kind of foundational base and definitions so that people understand what we're talking about when we talk about measurement-based care and we talk about quality from a theoretical perspective. And so when we think about measurement-based care, we're talking about use of repeated validated measures to track symptoms and outcomes in the clinical setting. And that means not just the behavioral health setting, but also in the medical setting as well. And the primary objective of this is to drive clinical decisions and help treat to target. And so if you think about kind of general healthcare, these are things that we do all the time if you're going to your PCP, but we don't do them so frequently within the psychiatric or the behavioral healthcare setting. So it's really important to sort of put on that hat and think about how do we measure care and how do we measure outcomes in this setting. Use of and measurement-based care also means use of measurement-based care in routine practice, improving outcomes, and in fact, some reimbursement and accreditation programs require the use of measurement-based care in behavioral health conditions. Next slide, please. So as I mentioned already, what does this really look like in real life or in the real world? We use validated measurement and treat to target all the time in the medical setting, including when we do a blood pressure or a pulse or a temperature, or when we do health screenings or management of chronic conditions like diabetes or high cholesterol or obesity. Next slide. But we don't do it, as I said, very frequently or consistently within behavioral health. And I think what we've learned is that when in fact you do use those kinds of tools or that strategy, that things get better. So sort of the most important paper that really defined this for the first time was the tipping point. And what it found was that looking at a research review of 51 studies that randomized controlled trials that included timely feedback of patient-reported outcomes or measurement-based care tools improved outcomes. So just the use of those scales led to improved outcomes, and that outcomes improved 20 to 60% depending on the study And that what they found was that within patients who received these kinds of scales, that 75% had higher remission rates versus routine care. Next slide, please. So one of the things that people have said over the years is, well, we don't really have validated tools within psychiatry and within behavioral health. But the reality is that there's a number of validated rating scales that can be used to both help to screen or diagnose conditions, but also to monitor their outcomes. This is a list of some of them. There's more, and many people are getting into sort of this game or into this place because of the things that we're talking about, the improved outcomes, as well as the opportunities that are related to actually delivering this kind of care. And in fact, we'll share with you all a copy of the paper that the Meadows Mental Health Policy Institute put together that talks about some of these measures and the science behind them, as well as many of the points that we're making today. Why measurement-based care matters is, as I said, it's clinically important. Patients get better simply because we measure their care and their outcomes. It can also help with accreditation. So if your agency is being accredited by the Joint Commission or URAC or other accrediting bodies, many of them are now requiring the use of these tools. And it really should be the foundation of quality measurement, which I'm going to talk a little bit about, which is important in many clinical settings, provider, hospital-based, et cetera, in terms of reimbursement and other things. Next slide. So talked a little bit about accreditation standards. The point is that most hospitals, health plans, many agencies or provider groups cannot get accredited without meeting a number of standards related to physical plant or responsiveness to patient needs, et cetera. And both the Joint Commission and URAC, which accredit various kinds of healthcare organizations, have recently added a standard for use in measurement-based care and accreditation, basically saying that all patients being treated in behavioral health for behavioral health conditions will be monitored using validated rating scales. Next slide. So what are quality measures? And this is kind of a complex kind of topic. What you've probably heard about is the move toward value-based care, which means moving beyond fee-for-service for reimbursement for services to saying we're going to take care of an entire population and we're going to look at their outcomes. And if their outcomes are good or better than usual care, then people will get paid more, essentially. And so quality is really the equivalent of outcomes. And so the idea is, the degree to which health services for individuals increase the likelihood of a desired health outcome is what quality is. And quality measurement is measuring those kinds of things in an aggregate sort of way. In other words, looking at data across an entire population or an entire provider group or an entire provider to look at how their outcomes or how they perform on these quality measures, which are supposed to reflect outcomes. Next slide. So what we know, though, that's interesting, and I think that over the years, people have said, well, this is burdensome and it's not important. But the reality is that when you do use those quality measures or quality measurement and you report on these things, that there are better clinical outcomes associated with it. Lower cholesterol occurred when health plans were required to were required to not only collect cholesterol levels on their patients, but were required to have a certain level on those cholesterol tests. And so when those provider groups were sort of held to that standard, in fact, their cholesterol levels went down. Same thing for hypertension, same thing for hospital-acquired infections, and improved depression screening. What we found is that when we started to require depression screening as a outcome measure, which was actually tied to reimbursement for clinics, that patients had higher rates of depression screening. However, not necessarily higher rates of depression remission. So it's important to use it not only in screening, but across a number of settings. As well, using quality measures decreases readmissions, improves adherence, and decreases time in emergency departments as some examples. Next slide. So what they should do is quality measures should reflect these kinds of outcomes. Here are some examples of all patients seen in a clinic who've got diabetes, how many show evidence of improvement in their diabetes. So the way that you would measure this would say the percentage of patients with diabetes in a health plan who have an HbA1c of less than 8.5. What you might do from measurement care perspective is you would get an HbA1c on your patient at a particular interval to make sure that their HbA1c was in fact reducing. So there's a number of these kinds of examples where we could use a PHQ-9 to measure depression, and that would help us to treat the patient. But when you aggregate that information, that becomes a quality measure. Next slide. Measurement-based care is, again, looking at the clinical process of care versus quality measurement, which is looking at reporting the data for accountability. And as I said, measurement-based care is really done on the patient level and really used to drive clinical care, but quality measurement is something that we do to look at an aggregation or a larger healthcare organization. Next slide. So, you all may have heard about some of these words, and measurement-based care are things, again, like the scales, the validated rating scales, PHQ-9 or a GAD-7, or blood pressure. Quality measures are things like the HEDIS set, which many agencies are required, and Medicare Advantage. A number of different healthcare plans use that to measure quality. In Medicaid, using the Medicaid core set, which has a number of behavioral health measures. And MIPS is the measurement program that's used by individual providers to measure their quality. I think these are, again, some examples of quality measure use in various types of programs. And again, a lot of this has to do with Medicare reimbursement. And so there are a variety of measures that are applied within inpatient psychiatric facilities, within Medicare STAR, the STAR rating program, which looks at Medicare Advantage and programs, in health, in HEDIS, as we've discussed, and MIPS, and also in the Medicare Shared Savings Program, ACOs, which I'm sure you've heard of. And what's really interesting in this, thinking about kind of both, thinking about the Medicare Shared Savings Program, is that it was in that setting that they required the depression screening measure, and that led to significant improvement in the screening rates across many healthcare settings, and impacting lots of patients' lives. Next slide. So finally, what I want to say is that, when we think about accrediting organizations, and we know that if you have to have a certain practice in place, that those facilities will in fact adopt those practices. The accreditation standard is a pretty strong leverage to get clinics and providers to actually use measurement-based care. And then secondly, if you know that these kinds of measures can be used to further increase reimbursement, then that's why the quality measure is really important. So both of them are important in terms of leveraging and incentivizing. I think the reality is that we've known for a long time that these measures work and that they impact quality of care, but they really haven't been adopted. And it's really important to adopt them for all of those reasons. And so the idea of being able to have those tools, both within accreditation programs as well as within the quality measure program, is really important. So American Psychiatric Association, with a grant from CMS, has begun to develop these types of quality measures that can be used by providers and hopefully others. And what they're doing is kind of converting or translating those quality, those measurement-based care standards or accreditation standards into quality measures. And the 5 measures that they have been developing, or that will be sort of ready for prime time very soon, include a measurement-based care process measure, which gives you credit for actually doing what we've just discussed, which is measuring a particular disease state or symptoms, and then repeating those measures to see how patients are doing. As well, it's looking at things, including a functioning outcome measure, which looks at folks with mental or substance use disorder who demonstrated improvement in functioning based on the use of a particular rating scale. The recovery outcome measure, very similar. As well, the APA is developing some additional measures on suicide safety planning and suicide ideation and behavior outcome measures. So again, all of these really focusing on the idea of getting people to do this practice, which we know is so strongly associated with improved outcomes, which is, while it would be great to be measuring all of those outcomes, again, with the heterogeneity of patients and the sort of the statistical piece around that, the idea is that if you can use a quality measure that in fact is highly related to a positive outcome, improved outcomes, then that, that in and of itself is something that can be effective. So with that, I will stop and Tegan, send it back to you.
Yes, thank you so much, Dr. Elter. You really set a great foundation for our discussion on measurement-based care today. We will invite you back later for question and answer. So thank you. Reminder to submit your questions. We will be hopefully answering some questions at the end. Okay, so for our second part of this webinar, I'd like to introduce Dr. Seema Shah. Dr. Shah is board certified in adult psychiatry and child and adolescent psychiatry. In 2013, Dr. Shah helped develop an integrated behavioral health program at Children's Health in Dallas. She led a team that provided behavioral health treatment, consultation, and education to 20 pediatric outpatient clinics that served approximately 80,000 children, most of whom were on Medicaid. In 2017, Dr. Shah joined the Meadows Institute and spearheaded the concept of a child psychiatry access program for Texas, now called the Child Psychiatry Access Network, which currently provides telehealth-based consultation and training to primary care providers across the state. Dr. Shah is on the board of directors for the National Network of Child Psychiatry Access Programs and has presented nationally on behavioral health integration at the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry. Thank you so much for being with us today, Dr. Shah. I'll let you take it from here.
Thank you, Tegan. Okay. Well, thank you everybody for having me here, and thank you, Tegan, for the introduction. So this portion is going to be focusing on measurement-based care in children and adolescents with some examples of validated rating scales. But before we get started, I just want to take a moment and reflect on why this is so important. So we know that half of all mental health conditions manifest by the age of 14. And 75% by the time that they reach age 24. So if we just take a moment to think about this, I think it's valuable because sometimes when we read these statistics, and this is myself included, it's easy to gloss over them and not really, take in what this means. Who are the individuals within this population? Chances are, many of us interact with children, adolescents, young adults on a daily basis. These are people within our communities. These are kids in your neighborhood. These are kids that you see walking to school, playing sports, studying at home, young adults who are currently in college or entering the workforce. And so, it's not really, they're not an insignificant part of the population who could have mental health needs. Now, the good news is that knowing this statistic can really help us identify a point in time where we have an opportunity to intervene and help prevent and reduce the severity of mental health conditions. So what are we doing about this? And how are we identifying these kids or young adults? Next slide, please. So as Carol mentioned, measurement-based care can help identify and inform the treatment of mental health needs. So we talked about administering validated clinical measures, and this can help address the gaps in identifying mental health conditions. Tracking symptoms through measurement-based care can inform not only how patients are doing over time, but also treatment planning. And together, these things can really improve patient outcomes and their overall satisfaction. Next slide, please. So the next part, we're going to talk about a few examples of validated rating scales in behavioral health for children and adolescents. Next slide, please. Okay, so some of you have probably already seen these or maybe using this in your practice. And there are certainly others. This is not a comprehensive list of all of the validated rating scales that are out there for children and adolescents, but for the purpose of this talk, we're just going to go ahead and go over a few. So for depression, we have the Patient Health Questionnaire, or the PHQ-9. There's also a modified version for adolescents, which is called the PHQ-A. For anxiety, we have two that we'll go over briefly. One is the screen for child anxiety-related emotional disorders, called the SCARED, and the Generalized Anxiety Disorder 7, or the GAD-7, which Carol also mentioned in the previous slides. Attention Deficit Hyperactivity Disorder, or ADHD, we have the Vanderbilt Assessment Scales. And for substance use, the example that we've included here is the CRAFT, which is a mnemonic for car, relax, forget, alone, friends, and trouble. And these words are actually embedded within questions of the CRAFT. And just, another note about validated rating scales such as these, they really can help supplement your evaluation. The information it provides can be used to help the clinician make important decisions about treatment planning. Next slide, please. So the first one that we're going to go over is the Patient Health Questionnaire 9, which is modified for adolescents, also known as the PHQ-A. The language in the question of the PHQ-A varies slightly from the PHQ-9. It has some more age-appropriate language, including irritability and questions around eating and weight loss that sort of more accurately capture how an adolescent might answer the question. And in addition, the PHQ-A has some questions around previous symptoms of depression and suicidality, which you'll see in a minute. Okay, and this actually, next slide, sorry. Oh, actually, can we back up one slide there? There we go. Okay, so one thing to note, the benefit of the PHQ-A is that it's freely accessible, ages 12 to 17 years old. Again, there are 9 questions. There are multiple languages there, especially with the PHQ-9. And one thing I also wanted to point out is that this form, the PHQ-A, can also be found on the Child Psychiatry Access Network website through the Texas Child Mental Health Care Consortium. Okay, go ahead, next slide, please. There we go. So I don't know if you're able to see this, the print might be a bit small, but I just wanted to show you, in case you hadn't seen this before, what the PHQ-A looks like. So again, it's a self-report measure that consists of 9 questions, and then there are 4 questions at the bottom that pertain to past symptoms of depression, functionality, and suicidality. So within the instructions, and this is the one tool that I'll sort of go into more detail since we have a little bit of time, but the instructions at the top ask the patient, how often have you been bothered by each of the following symptoms during the past 2 weeks? So the patient then puts an X in the box that describes how they have been feeling in terms of frequency in response to each of these questions. So they could choose not at all, I've been feeling this way several days, or more than half the days, or nearly every day. And each of those responses gets a score. So if we go through the questions, and again, this may help you understand what a child or adolescent might be experiencing when they're given this questionnaire, what types of questions are being asked. So question 1 is feeling down, depressed, irritable, or hopeless. Again, they have the choice to respond not at all, several days, more than half the days, or nearly every day over the 2-week period. Question 2 refers to, have you had little interest or pleasure in doing things? Question 3 is trouble falling asleep, staying asleep, or sleeping too much. Question 4, poor appetite, weight loss, or overeating. Question 5, feeling tired or having little energy. Question 6, feeling bad about yourself, feeling like you're a failure or that you have let yourself or your family down. Question 7, trouble concentrating on things like schoolwork, reading, or watching TV. And question 8, moving or speaking so slowly that other people have noticed, or perhaps being more fidgety and restless, more than usual. And question 9, do you have thoughts that you would be better off dead or hurting yourself in some way? So, and if there's a positive response on question 9, which is really getting to suicidality, that warrants further discussion with the clinician administering the PHQA to determine, next steps in the evaluation of a suicidal patient. Next slide, please. So here again, we won't go into this into significant detail here, but this is an example of a sheet that helps you score the PHQA. Again, this can be found on the CPAN website. So, that can be helpful just to have those things with you as you're scoring. So the scores for each of the 9 questions are added together and they create a severity score that you can record at the bottom of the PHQA form. And the score can range from 0 to 27. In general, if the patient scores a 10 or more, that has good sensitivity and specificity for major depressive disorder. Next slide, please. So here we have 2 validated rating scales for anxiety, the SCARED and the GAD-7. Again, both are freely accessible in multiple languages. The SCARED is for children ages 8 and up, and the GAD-7 is for children ages 12 and up. The SCARED has 41 questions, and there's a parent and child form, and when you score the results, the symptoms are placed into various categories that are associated with generalized anxiety disorder, separation anxiety disorder, panic disorder, social anxiety, and school avoidance. And the GAD-7 is really just focused on generalized anxiety disorder. It may be, overwhelming to say, how am I going to give a patient or their family, something like the SCARED, which has 40 questions or so, but it actually can go quite quickly. Next slide, please. And on to ADHD. Again, many of you may be familiar with the Vanderbilt assessment scales. Again, the nice thing is that this is freely accessible. It's validated for ages 6 to 12 years old. There are 2 assessment components, an initial and follow-up for parents and teachers. And this is also available in multiple languages. And again, this form can also be found on the Child Psychiatry Access Network as well. The initial assessment scales also have a few components that can help with some symptoms associated with oppositional defiant disorder, conduct disorder, and anxiety and depression. Next slide, please. This one is for substance use, the CRAFT, again, which stands for car, relax, alone, forget, friends, and trouble. And it's a brief validated measure for substance use disorders and can be used with adolescents starting at age 12 and up through age 21. Again, freely accessible, age 12 to 21. The latest version is the 2.1 plus N and has 10 questions and then additional questions related to nicotine, and it's in multiple languages. This one, the CRAFT, is typically used in pediatric primary care settings to identify substance use, but also substance-related riding and driving risk. And this updated version of the CRAFT also includes vaping as a method of substance use, in addition to nicotine and tobacco use. The nice thing about the CRAFT is that it can, help the provider develop a strategy for early intervention and patient-centered counseling and overall treatment planning. And the manual actually does a really nice job of going over, as a provider, how you can engage in these discussions with your patients depending on the level of severity that they are scoring on this tool. Next slide, please. So we reviewed, a few examples of validated rating scales for depression, anxiety, and substance use. And I just want to end by highlighting some additional benefits. So, implementing measurement-based care, it makes good sense in terms of quality of care for the patient, but it also helps reduce stigma associated with mental health. If all children, adolescents, and adults included were sort of asked these questions as a regular part of their visit, then it becomes a natural part of that process. It's not something new or novel. Mental health is seen as an important part of the visit in addition to their physical health. It also, by the patient filling out these forms, allows some insight on their mental health symptoms. So they start to pick up on, okay, if I'm filling out a screen on depression, sleep is important, appetite is important, energy, all of these things. And so they gain that knowledge through filling out these forms. And when you're reviewing the form with the patient, it can be a really wonderful opportunity to engage in discussions and have education on, topics that might come up while they're filling out the question. So, it can be an opportunity to talk about, if you're having trouble with sleep, we can talk about sleep hygiene. If your weight is shifting here or there, it can be an opportunity to talk about nutrition and so forth. And so it can be actually a bridge to communicate with the patient on what they're experiencing. And then lastly, but certainly not least, it can be helpful data for communication amongst providers. So sometimes when patients are transitioning from one provider to another, having data such as this in a validated rating scale can be really helpful when you're trying to see, what was the level of severity that somebody may have been experiencing with depression in the past, where have they been scoring more recently, and how did they respond to a certain treatment, and using the validated rating scale to help with some of those decisions. And Tegan, I will turn it over to you. Thank you.
Thank you so much, Seema. It's always great to have you and to hear from you. So we'll invite you back for questions at the end as well. So for our final presenter today, I'd like to introduce Dr. Andrew Carlo. Dr. Carlo is a board-certified adult psychiatrist with extensive experience in physical and behavioral health integration in primary care, both clinically and in the areas of billing and management. Dr. Carlo also has extensive research experience in health services and health policy, with a particular focus on behavioral health integration and the collaborative care model. Dr. Carlo is a part-time assistant professor at Northwestern Feinberg School of Medicine in Chicago, where he is involved in the institutional collaborative care program implementation. At the Meadows Institute, he serves as our senior medical director for health system integration and plays a leadership role in our multi-pronged approach to adoption of collaborative care and health system integration. He assists our partners with adopting best practices in financing and clinical workflow when implementing collaborative care. Thank you so much for being here today, Dr. Carlo, and I will let you take it away.
Thank you very much, Tegan. And I'm very excited to be here and presenting with Drs. Alter and Shah on this really important topic. Let's go to the next slide, please. So I'm going to talk, take it kind of down the line a little bit from where Drs. Alter and Shah have been talking about measurement-based care to the implementation and sustainability phases. So how do we actually get this into practice, and how do we make it, once we get it in practice, how do we make it sustainable and effective? Next slide, please. So as we've already heard today, measurement-based care is being used in clinical practice already. It's being used for screening. It's being used to follow outcomes longitudinally as well. We primarily see this in medical settings, however. So settings like primary care, family practice, pediatrics, and even in specialty medical settings like obstetrics or cardiology. We see measurement-based care a lot also in integrated care models. I'm going to talk specifically about the collaborative care model of behavioral health integration, where measurement-based care is an integral part of the treatment plan. We see measurement-based care in schools, which we've already heard about extensively from Dr. Shah told us about how these measures are used in children and adolescents of various age groups. Schools have adopted measurement-based care, and they've been doing that for quite a while. In justice settings, we see measurement-based care, including jails and prisons. And then we do see some measurement-based care implementation in specialty behavioral health, although less so than these other settings. Next slide, please. So I mentioned the collaborative care model for behavioral health integration. Some may be familiar with this model. I'm just going to briefly describe how it works to show you how measurement-based care plays into the model. Collaborative care is a model of behavioral health integration where a team of providers works together to manage common behavioral health problems like depression or anxiety right in the medical setting. So like a primary care setting or a pediatric setting. In the model, the treatment team is actually includes 3 different providers. There's the primary medical provider or the pediatrician. There's the psychiatric consultant, which is someone with expertise in psychiatric medications. And then there's the behavioral health care manager. And these three individuals work together to manage a whole population of patients who have common behavioral health conditions. And the reason why I bring this model up is because this model includes a treatment registry, which you can see in the graphic on your screen. This is an example of what a treatment registry can look like. And in the registry, all patients that are referred to the program and enrolled in the program have their own line in that registry. And over time, you can see that a lot of things about the patients are followed. But right front and center, you see the PHQ-9. And I wanted to highlight that to show this is how collaborative care incorporates measurement-based care. Not only do we screen patients when we, in primary care and then refer patients who screen positive, but we follow their outcomes very rigorously over time. And we keep them in this registry so that nobody falls through the cracks. So we know that if they had a PHQ-9 score 6 months ago, and then they had a follow-up 4 months ago, and then we haven't seen a follow-up score since 4 months ago, that we probably need to reach out to that patient. So measurement-based care is involved in every facet of collaborative care. So I think it's a good example of how it's implemented. And because the collaborative care model has been implemented so widely, measurement-based care has therefore been implemented widely as well. Next slide, please. We heard a little bit earlier from Dr. Alter about treatment to target. This is a really key concept. And one thing I wanted to expand upon a little bit more is what does treatment to target mean? What is our target? When we have outcomes using these evidence-based instruments like the PHQ-9, it's really helpful to know how do we interpret the changes over time. So we know that we might know when someone screens positive on the PHQ-9, and we might know what's indicative of severe depression on the PHQ-9. But do we necessarily know how to interpret a change from a 21 to a 10? What does that mean? Well, a lot of people have been asking these questions for a long time, going back to when the PHQ-9 was first created and validated. But I wanted to kind of just go over that a little bit today to explain when we say treatment to target, what we really mean. Oftentimes with the PHQ-9, you're going to see the PHQ-9 as an example often today because it's so commonly used. This would also apply to other instruments, but I'm going to just use the PHQ-9 as an example. So we usually define treatment progress with the PHQ-9 through significant improvement, response, and remission. There's been many other terms that have been used, and also these terms are not always defined the same way. I just wanted to kind of give you a sense for the way that they're often defined. You may look in the literature or in health systems and see different metrics used. That's totally fine, but I just wanted to show you some examples. Depression significant improvement is often defined as a PHQ score change from baseline of greater than or equal to 5 points. So from a score of 21 to a score of 15, that would be considered depression significant improvement. Depression response is usually defined as a PHQ-9 score change from baseline of greater than or equal to 50%. So in other words, a score from 21 to 10, that would be considered depression response. Depression remission is actually a cutoff, so it's slightly different. It's a PHQ-9 score of less than 5, and the sort of subtext to that is for a patient who previously met criteria for depression, which is usually defined as having a PHQ-9 score of greater than or equal to 10. So if you go from a score of 11 to a score of 4, you've actually achieved depression significant improvement, response, and remission. But you could obviously see there's other score changes that would not meet all the definitions. So that's how we often think about treatment to target. in measurement-based care, and this is used often in integrated care programs as well. Next slide, please. So we've heard a lot about the benefits of measurement-based care today already from Dr. Shah and Dr. Alter. And I think a couple of I sort of peeked at the questions. There was already some people asking about, how about the implementation? Why have we not fully implemented this? Well, there's a number of reasons why measurement-based care is difficult to implement, but most of these reasons have been mitigated time and time again. The first that I want to discuss, though, is that measurement-based care in mental health, it's basically 100% patient-reported. And when we say patient-reported, we mean that the patient has to provide the information directly to the clinician in one way or another. So they either say it out loud or they have to fill out a screening instrument. This is different than other types of healthcare, right? Where for measuring cholesterol, the patient has to have their blood drawn. For measuring blood pressure, the patient has to allow us to use a blood pressure cuff. In mental health, we actually have to ask the patient more. More is asked of the patient. And when we do this repeatedly over time, it does take a little bit more effort. Also, we know clinical settings, there's a lot of competing priorities. Even though clinicians can go to a talk like this and say measurement-based care is really important, I want to do this in my practice, we understand that there's a lot of other priorities, things that are going to compete with measurement-based care for implementation focus. Measurement-based care, like I said, it takes a little bit of effort to get this information from patients. And when we do this repeatedly over time, it does take time in the clinical encounter, which we know is in high demand. Another barrier is that sometimes when people screen positive, clinicians wonder, what do I do next? So if someone has a high score on the PHQ-9, the clinicians have always struggled to find behavioral health care for their patients. So they might say, well, now I know more patients are depressed. Do I really have the resources to help these people once I find out that they're much more depressed than maybe I never knew before? On top of that, we sometimes unearth information that is, there's a liability concerns. This is most commonly found with suicidal ideation. The PHQ-9 question 9 asks about suicidal thoughts or thoughts of self-injurious behavior or passive death wish. And so when we learn that information, there's a liability associated with it because it's obviously a crisis situation, and clinicians sometimes don't have a clear pathway to provide services for those patients. There's also a need for technological infrastructure so that measurement-based care can effectively be conducted. So not only do we have to have the PHQ-9 score from today, I also need to know the PHQ-9 score from 6 months ago and 2 years ago. And I need that all to be available to me right in the clinical encounter. As all clinicians know, our medical records have a lot of information, but oftentimes it's not all in the same area that we're used to being in the medical record. It might be on a different tab or in free text. And so when the information is not readily available in real time, it's right in the clinical workflow, it's not as helpful. And then we might have things like we have a PHQ-9 score from today, but I don't know what their score was 6 months ago, so it's hard to know what to do with that information. Also, there's reimbursement challenges, which I'm going to talk more about on the next slide. So measurement-based care, luckily, has some funding streams. Some of these are available right now, ready to use. Some of them are considerations for the future. So I'm going to talk a lot about Texas Medicaid today. Also, of course, there's Medicare and there's commercial payers. So this is obviously a very complicated topic. I encourage anybody with specific questions to speak to your local financial expert at your practice or your health system. I'm going to try my best to provide something that'll be useful for everybody today. So Texas Medicaid and major commercial carriers do reimburse for screening and follow-up assessments. Measurement-based care can also be reimbursed as part of an integrated care model. So that includes the collaborative care or other integrated care models. Next slide, please. So behavioral health screening is actually billable as part of the Texas Health Steps initiative. This is reimbursed through Texas Medicaid and commercial carriers. For the Medicaid beneficiaries, the child, because we're talking mostly about children in this particular case, the child has to be between the ages of 12 and 18 years old. And also for Texas Medicaid, the screening has to be with a recognized quote unquote instrument. And the recognized instruments are defined as such. These are all instruments that are considered recognized for Texas Medicaid as part of the Health Steps program. You can see that the PHQ-9 and the PHQ-A are listed in addition to other instruments. Next slide, please. So the codes for behavioral health screening in this Texas Health Steps context are 96160, which is for a screening tool completed by the patient. We heard from Dr. Shah how some of these are completed by the patient, some are completed on behalf of the patient. For the latter situation, the 96161 code is the one to use. Texas Medicaid will only reimburse for either code once per patient per year. And additionally, there's a caveat that this code has to be submitted on the same day of service and by the same clinician as a preventive medicine procedure code. So you can see where these codes are designed to be used in the medical setting. And you can see that they can be used for an initial preventive medicine visit or also an established preventive medicine visit. Remember that there's certain age requirements for different payers. And of course, the requirements do differ across payers. So again, I encourage you to speak with your local finance expert if you have additional questions. And I also wanted to say there are other codes that can be billed for behavioral health screening or longitudinal outcome assessment. They're not necessarily billable through Texas Medicaid, but they could be billable through Medicare, which of course doesn't cover many children, or commercial carriers. Next slide, please. I want to talk a little bit about the behavioral health integration codes. Now, these codes were created, they're fairly new still. They were created by CMS in 2017. They were designed to reimburse for different types of integrated care. So the collaborative care model that I talked about earlier, which is a very specific model with very specific components, and then also general models of behavioral health integration. These codes, which are not yet active in Texas Medicaid, they are active by major commercial carriers and also for Medicare. Not yet Medicaid. We expect Texas Medicaid to cover the collaborative care codes in 2022, sometime by mid to late 2022. And I'm going to talk more about this in a couple of minutes. So these codes offer a lot more flexibility than the behavioral health screening codes that I discussed previously. They don't have any age or diagnostic restrictions. They don't stipulate that you have to use a certain instrument for measurement-based care. They also, although they do require you to have a behavioral health care manager of some kind, they don't specify which background or credentialing that specific person has to have. So they do offer some flexibility. There's 4 collaborative care codes. Again, these will be active in Texas next year: 99492, 99493, 99494, and G2214. To build these codes, you have to be doing collaborative care by the book. You have to have the registry. You have to be doing the measurement-based care. You have to have a psychiatric consultant. You have to have systematic review of the registry as well. Most commercial carriers already cover these codes, and Medicare, of course, already covers these codes. There's also the general behavioral health integration code that has not been approved by Medicaid in Texas either. It may be reimbursed by commercial carriers, and it is reimbursed by Medicare. But that model is, next slide, please. The general behavioral health integration code is 99484, and that covers all other types of integrated care models. I shouldn't say all. It covers many other types of integration that don't quite meet criteria for collaborative care. So if your practice has other components of integration that aren't necessarily the collaborative care model, you may be eligible to bill this 99484 code, which the time spent delivering integrated care would include measurement-based care, and it may be eligible for billing through 99484. Again, this is not yet billable by Texas Medicaid. We actually don't know whether Texas Medicaid is going to activate this code, but this code is active for Medicare, and it is active for many commercial carriers as well. So again, the disclaimer is please check with your local finance expert. And with that, I will finish up, and we're happy to take any of your questions.
Thank you so much, Andrew. I'll invite Seema and Carol to join us too. We've had a number of questions come in, and so let's just dive right in. And Andrew, I'm going to start with you because the billing stuff is fresh in everybody's minds. So we've got a few questions about billing. So the first one is, are there related codes for telehealth?
For telehealth, well, I guess I'd have to sort of ask a follow-up question. Telehealth administration of measurement-based care, or just measurement-based care? Is that what
I'm going to say that? I'm going to say yes, administration of measurement-based care, or maybe even the screeners.
So for Medicaid, the code has to be billed on the same day and by the same provider as a preventive medicine visit. So I believe that as long as that criteria was met, that the code would be billable through telehealth. For the other measurement-based care codes, the ones that I didn't specifically go over because they're not they're not active for Texas Medicaid. I don't know offhand whether those would be billable through telehealth. I don't know. That's a good question. Certainly anything in the collaborative care or general behavioral health integration context, that is totally billable through telehealth. The collaborative care codes and the general behavioral health integration codes have always incorporated telehealth as part of the model, and all the minutes that are delivered through telehealth count toward monthly totals that then determine which codes are billed per month.
Thanks. So a similar question is about outpatient mental health providers being reimbursed for administering screeners as part of their intakes. It sounds like billing is mostly linked to Texas Health Steps. Is that with the medical visit, or are there other opportunities to bill for screeners in an outpatient mental health setting?
So for Medicaid, if the question is specifically about Medicaid, the billing for screening is limited to the same provider in the same day as that preventive medicine visit. It can be an initial preventive medicine visit, but I don't believe that's what the person is asking about. I believe they're asking about a specialty behavioral health visit. So in that case, I don't think Texas Medicaid would reimburse. I think through other payers, there may be options for reimbursement, though I don't believe they'd be available through Texas Medicaid. Not any codes that I'm familiar with at this point.
I'm wondering at what you all think. Another question came in about whether outpatient mental health providers are using screeners, and if so, why not? And perhaps the billing issue might be one. Is that your all sense as to why outpatient mental health providers may not be doing things like the PHQ-9 or as much as you see it in a medical setting? What are your thoughts on that?
Well, I think that I think there's a few answers to that. I think one answer actually is more cultural than it is operational. I think that historically, at least psychiatrists, and I'm not sure about psychologists and others, well, I think that behavioral health providers in general have felt that our ability to do an exam and an evaluation, which largely incorporates much of what are in those screeners or those dimensional rating scales, that we're better than the scale. And that, and in fact, there's also been a fair amount of overt resistance, at least in psychiatry, of requiring these scales. Again, I think for fear that they would, it would sort of impair our ability to practice in some kind of crazy way. So I think there's a very strong cultural issue. And in fact, in the DSM-5, when they were trying, it was actually suggested that in the DSM-5 that there was a third section in there that were these dimensional rating scales, and that they would be required for making a diagnosis. But the American Psychiatric Association said, no, don't want to do that. And I think part of it actually was, it was both this sort of sense of the work that we do, but I also think it was, or the way that we, people think work should be done. But I also think that it was some concern about reimbursement. So I think that that's one piece. I think that what we've learned since we've been on this mission for measurement-based care, which is what it feels like in many ways, that it's hard to do because none of the tools because while there may be tools available in electronic health records and things like that, that they're never easy to use. And so because it's not part of the practice of what we do, it becomes kind of a vicious cycle, then it's not part of the practice of what we do. So so I think but that is something that we're working on in a variety of different settings. I think that's a lot of what we're doing with the Lone Star Prize throughout the state, is really trying to address those issues. I just want to make one other comment about the billing piece. Just going back, because I think it's important. I don't know if any of your agencies are being accredited by either the Joint Commission or URAC, or potentially there's other agencies that do accreditation in mental health providers and healthcare settings. But I think one of the reasons that we were we've been trying so hard with some of these quality measure routes and through accreditation is that the reimbursement, in fact, is not perfect. And in fact, when certain like United or Aetna many years ago had provided reimbursement for the PHQ-9, and the primary care docs just felt like it was such a small amount of money that it wasn't worth all of the work to sort of get it reimbursed and blah, blah, blah. But I think that this idea of sort of leveraging that it becomes part of what you do is important, and that those kinds of accreditation standards, just like we have lots of other accreditation standards of what we do, actually, may fuel the behavior change. That said, I still think we should get paid for doing it. There you go. Meaningfully.
Nice.
How about that?
Yeah. I like it. Excellent. Well, I'm going to sneak one more question in, and that was for you, Dr. Shah, about if you're going to provide, what would you recommend in a school setting, providing a universal screener, the PHQ-9 or the PHQ-A? Is there one that would be a better fit than another for a school setting?
Thanks, Tegan. They're both, as you saw in the Texas Healthy Steps as an example, they're both sort of approved. I think, the benefit of the PHQ-A is that, again, the language has been adjusted to reflect, what an adolescent might be feeling. And then there's some questions about previous symptoms of depression. So I don't think you can really go wrong with either one. Both are good. Tegan, I also just wanted to add on the comment of sort of adopting measurement-based care in practice. I think, from the child and adolescent perspective, I think sometimes providers are reluctant to give a questionnaire to a teen or adolescent because there may be some fear that the patient or family may somehow get offended that they're being given this rating scale. And so, again, this sort of gets back to the stigma, and probably more in primary care than specialty care. But in actuality, there have been studies that have shown that, some patients really like filling out these validated rating scales because it indicates a level of comprehensiveness and thoroughness that is occurring during the visit, and it allows them to sort of express themselves with the provider. And I think that, giving children and adolescents sometimes don't have the opportunity to express how they're feeling, or they're not sure how, or they may be fearful themselves. And so by providing them that tool, it's a way for them to have a voice in a meaningful way. And that, I think it can also make them feel okay about filling it out because, oh, this is actually, this is printed on a paper. This means that other kids are getting this, rating scale to fill out as well. So I'm not alone in this, right? This is just a part of the normal visit, which I think is an important message.
Yeah, thank you for sharing that, Seema. I can appreciate that it gives an opportunity to maybe share some information that you want to share but don't quite know how to, and then just having that be part of business really normalizes the experience. So can definitely appreciate that. Well, we are bumping up against the very end of time. So thank you three all so much for being here and sharing your knowledge and expertise with us. We really appreciate it and have learned a lot today. And to our audience, thank you all so much for joining us. We hope to see you next time. Mark your calendars for December 1st at noon. We're going to be having our last speaker series session, which will be on the topic of collaboration and the factors that make it work across communities. So we're going out on a high note here too as well. So join us next time. We hope to see you soon. Have a great afternoon.